Hello everyone, welcome to QXon. In this video, we will discuss some important clinical cases of gastrointestinal system. So we will discuss Achalasia cardia, gastroesophageal reflux disease, steatorrhea and secretory diarrhea. So let us see our first case. A 32-year-old woman presents to the OPD with dysphagia to solids and liquids with associated weight loss since 2 years. Barium swallow shows rat tail appearance. Esophagoscopy shows retained food at the lower part of the esophagus. Esophageal manometry reveals increased pressure over the lower esophageal sphincter. So what is the most probable diagnosis in this case? See, in this case, the woman is having dysphagia, that is difficulty in swallowing to both solids and liquids, and it is a chronic condition. See, it is since 2 years, and along with dysphagia there is associated weight loss. Then barium swallow shows rat tail appearance. Basically in barium swallow, the person drinks a solution of barium sulfate and then X-ray is taken, because what happens is barium coats the lining of the esophagus and stomach and thus makes them opaque. So X-ray shows the structural aspects of esophagus and stomach. Then esophagoscopy shows retained food at the lower part of the esophagus. So a tube was put via the esophagus and shows that the food is retained at the lower part of the esophagus. That means it is not moving into the stomach. Then to find out the cause, esophageal manometry which was done reveals increased pressure over the lower esophageal sphincter. So as the term indicates, manometry. That means that the pressure was being measured at various points in the esophagus and it revealed increased pressure over the lower esophageal sphincter. So all these points point towards the diagnosis of Achalasia cardia, in which lower esophageal sphincter basically fails to relax. So if it doesn't relax, the food doesn't enter into the stomach, right, and is retained in the esophagus. So let us solve other questions related to this. That is, add a note on the lower esophageal sphincter. What are the types of esophageal peristalsis? What is the treatment of this condition, that is Achalasia cardia? And there is one carcinoma which is associated with this condition. So what is that carcinoma which is associated with this condition? So as said, the diagnosis is Achalasia cardia. Then our question was a note on lower esophageal sphincter. Well, lower esophageal sphincter is basically a high pressure zone with a pressure of approximately 10 to 45 millimeter mercury, and it basically relaxes when the food has to pass from esophagus to the stomach. Otherwise, it is kept in a constricted condition, and this prevents the reflux of gastric contents back into the esophagus. Now, second question was the types of esophageal peristalsis. Well, there are two types of peristalsis. One is primary peristalsis, which is a part of deglutition reflex. Our deglutition reflex has three phases: oral, pharyngeal and esophageal. And this esophageal phase basically is a primary peristalsis. So it is in continuation with the deglutition reflex. And this pushes the bolus into stomach. On the other hand, sometimes this primary peristalsis may not be sufficient to push the bolus into stomach. For example, suppose the bolus is quite large. In that case, secondary peristalsis comes into play. So what happens that the bolus causes the distension of the esophageal region where it is stuck, and it leads to the activation of mechanoreceptors. So this secondary peristalsis is initiated when primary peristalsis fails to push bolus. And if we try to differentiate it from primary peristalsis, then you see that primary peristalsis is preceded by the oral and pharyngeal phases of deglutition reflex, while secondary peristalsis is not. Then, what is the treatment of this condition, that is Achalasia cardia? Well, we have said that what is the problem in this condition? Well, it is the lower esophageal sphincter is failing to relax. It is kept constricted, and that is why in esophageal manometry we got a high pressure zone. So what should we do? Well, we should try to relax it or stretch it, right? So yes, the treatment is such that to target the stretching and relaxation of the sphincter. So first is the pneumatic dilatation. In this, basically a balloon is inserted by means of a esophagoscope into the lower part of the esophagus, and the balloon is distended. So this causes the stretching or relaxation of the lower esophageal sphincter. Then next can be surgical treatment, that is Heller's myotomy. In Heller's myotomy, a part of the lower esophageal sphincter muscles is cut, right? So as the name suggests, myotomy, part is cut, and this will cause the opening to be of little more size, right? But you see, we said that the function of lower esophageal sphincter is preventing reflux of gastric contents into esophagus. So if we cut some muscles of lower esophageal sphincter, it can promote the reflux of gastric contents, right? So this Heller's myotomy is generally combined with what is known as fundoplication. So in this case, the stomach is wrapped up, the upper portion of stomach is wrapped against the lower portion of the esophagus so that it acts as a functional valve, right? So Heller's myotomy combined with fundoplication. And third method of treatment is botulinum toxin injection, and it is done in patients who are not the right candidates for the first two treatments, because this botulinum toxin injection requires repeated injections. So what happens that this botulinum toxin causes relaxation of the muscles of the lower esophageal sphincter. So three modes of treatment: pneumatic dilatation, Heller's myotomy, and botulinum toxin injection. Finally, the question was that which carcinoma is associated with this condition? Well, it is squamous cell carcinoma which is associated with achalasia cardia.